Talk about molecular characterization of neuroblastoma, which is, of course, a complex issue. And I thought maybe it's a good idea to take you all the way from where we come from when we started with molecular characterization like 25 years ago and how we developed stepwise and where we are today. So I'm from Berlin at Charité. And at Charité, Rudolf Virchow did his research activities, and Rudolf Virchow is the one who first described neuroblastoma back in 1858. So he was the first looking at cells in tissues and described what he's seeing. He didn't call it neuroblastoma by that time, but what he describes in his reports clearly is neuroblastoma. And by that time, he said medical research is based on 3 pillars. It's based, of course, on clinical examination of patients. In his time, it was heavily based on animal experiments and also on anatomy. And he collected all the tissues that he found diseased and tried to learn something for treatment. Today, we think we are rather in the age of Virchow 2.0, so we have at least 4 pillars of research. So we still, of course, examine our patients and image them with CT, with MRI. We use, rather than animal experiments, more patient-derived models nowadays. But we heavily rely on sequencing, and the latest technologies adding to these are so-called single-cell technologies. And meanwhile, the data volumes are so high that we need artificial intelligence to analyze them. Otherwise, it would not be feasible to learn something out of these high-volume data sets. So our aims today are targeted intervention in the sense of personalized medicine, but also to intervene as early as possible, so not, if possible, not to wait until we have a very extensive high-stage disease, but maybe if we can identify in the future the first diseased cells, this would be very helpful in our chance of cure. So in neuroblastoma, why do we bother about molecular characterization at all? So it started with the field of risk stratification to answer the question who needs therapy and why, and maybe even how much and how aggressive the therapy should be. And the start were in the year of 2000 approximately, so-called microarrays, and they looked like this, little chips where we could analyze the DNA and mRNA of our patients, and then we got these little red and yellow and green pictures and had to make sense out of it. So with these technologies, molecular diagnostics started in the early 2000s, and then we had the first reliable results between 2005 and 2015 towards a more reliable risk prediction that is not only based on clinical risk factors, but also on molecular data. And most advanced in the early beginnings was mRNA expression, so to say, the molecules that deliver the DNA message into proteins. And we could show quite early internationally that molecular risk prediction is better than the clinical parameters alone, and that we can better learn to discriminate how aggressive a neuroblastoma is and how much treatment it might need accordingly. The same then developed with DNA, but also so-called microRNAs and DNA methylation. So there are a lot of molecular levels and a lot of molecular patterns that you can analyze and potentially use for risk prediction. In Germany, we had in 2016 the first prognostic classifier ready for treatment stratification, and this is work of Matthias Fischer, who you see in this picture, and his team in Cologne. And this classifier was analyzed and validated in more than 700 neuroblastoma samples, and reached a very high accuracy of 95% and a high sensitivity and specificity, although within the group of high-risk neuroblastomas it was a little bit less convincing. But it was reliable enough to come up with a new risk stratification system in Germany that is since then not only based on the age of the patient, the stage, but also on gene expression classification based on 144 different genes. And by deciding if this gene expression classification gives us a more favorable or a more unfavorable picture. And with a complex algorithm like the one you see here, we now decide which patient we can only observe, low-risk patients, which patients do need an intermediate risk treatment, and then, of course, also the ones who have stage 4 disease, metastasized disease, McN-amplified disease, they, of course, need high-risk treatment, but still it's important to also have this group in mind if we want to find out more about molecular characterization and how we can make use of it in the clinic. So then in 2012, roughly, the era of so-called next-generation sequencing started with new technologies, whole genome sequencing, targeted sequencing coming up. And of course, the neuroblastoma community always used very fast these new technologies coming up. And we also learned new insights into the pathogenesis of the disease, how neuroblastoma is developing, what are important features like the TERT expression that has been discovered by whole genome sequencing approaches. So also about the biology and why neuroblastoma develops, we can learn a lot by implementing molecular characterization. And based on that, a new mechanistic definition of clinical neuroblastoma phenotypes came up, again sorting the patients in very high risk, and low risk, and describing what is the biology behind these risk groups. The second, and that's even more important, we use molecular characterization to identify new targets, because for some of our patients, we get into the situation that we cannot rely on established treatment protocols anymore, but we need to find experimental approaches, targeted approaches, and then we need to know what targets we might have. The first publication on the genetic landscape of neuroblastoma came from our American colleagues in John Mary's group in 2013, and it was immediately clear that there is a clearly described landscape, genetic landscape, but that it's not so heterogeneous, and that there are only a handful of genes, of mutations that might serve as targets for new treatments. The sequencing methods over time improved, and so we had new technologies at hand, and that resulted in an update of a new genetic landscape in 2020. But still, the targets remained more or less the same, and one of the most prominent targets that you all will have heard us is ALK, the anaplastic lymphoma kinase, where we already have targeted treatment around. Of course, these sequencing approaches can identify ALK mutations, which are present in 8 to 10% of the patients, and that we can use for additional treatment of high-risk patients. For most of the other targets, treatment are still under development, and we do not have any first-line clinical trials open yet that are making use of these targets. ALK inhibitors, on the other side, are a really success story. It started when ALK mutations were first described in 2008 by Yael Mosse and other colleagues here in the US, but also in France and in Japan. And since then, a lot of lessons have been learned about ALK mutations, how they work in their biology, what they mean for the patients, and how they can be targeted, and how we can meanwhile also use them for liquid biopsy diagnostics, for example, to monitor the disease. And at the moment, we are launching the first ALK inhibitor first-line treatment protocol in Europe, and also here in the US, ALK has found its place in first-line treatment. This is our current treatment strategy in Europe for high-risk patients. And what is very important, if we get into the situation of a relapse of a high-risk patient, then we need to have very detailed molecular characterization information at hand. And this is an overview of the pediatric cancer precision medicine programs that are ongoing worldwide. And in our Western countries, there is a good offer and good access to these precision medicine programs. However, it's also clear that many countries in Africa, in South America, in Asia do not have access to these programs. And this is, of course, also one of our global health tasks to how to improve this, that every child with neuroblastoma in the world can get access to such a program. There are more than 5,000 samples, pediatric cancer samples already sequenced. More than 1,000 new patients per year get analyzed in these programs, and they are very helpful in finding targeted therapies. In Germany, our program is called INFORM, and when we have a look into INFORM results for neuroblastoma, we can state that more than 250 neuroblastoma patients, relapsed neuroblastoma patients, have been analyzed in this program, and 52% of these patients have shown targets with high or moderate priority according to a defined score. But still, it's only a handful of established targets. And if we have a look what this means for the patients, only 4% of patients have been included in clinical trials. And the major reason for this is that not for all of these targets there is a pediatric clinical trial open and around. And we have to have better dialogues with industry to open more pediatric trials and also open more combination pediatric trials so that every patient can be offered a clinical trial. In France and in the Netherlands, it's a little bit more, but there they count not only clinical trials, but also registries. And at least in the Netherlands, 24% of patients get match-targeted treatment who show a respective target. We know and we can very detailedly describe the mutational landscape of relapsed neuroblastomas. We know the frequency of the different targets. So that's all in a very good shape. But still, even if we treat a child according to a new target that we have identified by the molecular characterization in this mutational landscape, only a few patients are really cured by that approach. And one of the reasons is that monotherapy, targeted monotherapy, results at some point in secondary resistance. So the tumor learns how to deal with this targeted treatment and switches the signaling pathways, and at some point it's not working anymore. So this is a problem we will have to solve. The question is, in addition, is a single biopsy sufficient for molecular characterization? As we know that in a tumor we don't have, and not every tumor cell looks like the other tumor cells. So there is heterogeneity, intratumoral heterogeneity, not only a difference between metastasis and the primary tumor. And maybe we are on the molecular side still not precise enough to get a really reliable and detailed picture also of this heterogeneity. We did an experiment a couple of years ago where we took 5 different biopsies in 5 different regions from the same tumor. And we found up to 35% specific mutations, meaning that not every mutation could have been detected in every of the 5 biopsies. So that's kind of a result that we have to keep in mind when we further improve our molecular characterization. So because it means we have still a somewhat imprecise prediction of therapy targets and therapy response, and we need to identify the clinically significant part of the neuroblastoma cells in the tumor for having a better therapy planning. The question is, can this be supported by liquid biopsies? And there are a lot of international efforts ongoing to make use of liquid biopsies. This is in most of the projects either blood or bone marrow of the patients. And there are a bunch of technologies ongoing how to learn about the disease, how to get to targets, but in particular also how to monitor the disease of the patients. In Berlin, we have developed a so-called multiplex quantification of DNA targets in a single reaction, and this is accredited according to medical diagnostics law, so we can use it for clinical decisions. And this is a technology that is focused to detect MUC-N amplification, ALK mutation, also in the future TERT rearrangements, and to follow these in the patient during treatment. And we can already show that for at least a part of the patients, we can identify a relapse approximately 3 months earlier than we can do this by imaging. So it seems to be a promising tool, but there is a lot of validation still needed and a lot of clinical trials needed before we can really be sure that we can use that for treatment decisions at a very early stage. There is a European trial called Mona Lisa that has started last year, which is trying to assess if liquid biopsy technologies can contribute to identify a relapse early, how reliable this is, if this has any consequence for treatment, also for then, of course, the outcome of the patients. And before this trial is finished, we cannot have very reliable results in this regard, but it's on the way, and I think the whole liquid biopsy topic is very promising. Liquid biopsies is more than blood and bone marrow, so in the future we will also be able to use urine and saliva and cerebrospinal fluid, maybe even stool, and all of this is on the way in different research programs, but it always takes, of course, a couple of years until new knowledge coming from research can be transferred to the patients. We still have a lot of further challenges to solve in research, and we may not only want to understand the tissues, the tumor tissues, but we need to focus on the different cell types in the tumor and to, in the future, more take single cell technologies into account. And of course, neuroblastoma is a field where this has been approached, and there will be great talks in the ANR meeting about single cell application. It starts always in cell culture models, and there have been quite interesting results on different neuroblastoma cell types or neuroblastoma plasticity that were derived from single cell analysis, but also on the tissue level, it's important to get insight into the spatial organization of a tumor. So what kind of cell types and clusters are located where, and what is the best way to target them there. And there are quite some commercial applications around which are quite expensive. So to use these commercial applications for one tumor sample costs around 5,000 to 10,000 euros at the moment. So that's to bring it really broad scale into the clinical landscape is too expensive. But there are new technologies coming up, and we have the first spatial cell atlases of neuroblastoma where we can learn new insights on the development, but also on tumor heterogeneity in total. In Berlin, one of our colleagues at one of the research institutions developed his own technology, which is more affordable, 250 euros per sample. And this we now try to transfer from shock frozen material to FFPE material, because that's of course much easier than to use in pathology, and we hope this will be successful in the upcoming years. What is most important, and what I would encourage everyone and also to discuss in your community, it is most important to take a new biopsy at relapse. We cannot rely on the molecular characterization of the first diagnosis when we get the tissue for the first time, because the tumor is developing under treatment in time, and this is called tumor evolution, and it really takes place. So we find different results after initial treatment, and if there is a relapse, we need to have a fresh biopsy to see if new targets have come up that we can then use for a targeted therapy. Of course, it's always taking a biopsy is always an approach for the child, but the information that we can gain is so helpful that it's definitely worthwhile to do so. So that was my very rough overview of what's going on at the moment in molecular characterization. There are great talks at the ANR meeting that give you much more detail what's going on. But I thought maybe it's also nice to have an idea how this all developed and where we are at the moment. And it's not the perfect way yet how to analyze a neuroblastoma, but every year we get closer to the perfect way. And it's a lot of research behind it, and we need to invest in this research because the better we know how the neuroblastoma is composed in the patient, the better we can choose a really tailored and targeted treatment in the future. And I think this will be the goal, not to treat every patient with the same approach, but to have an individual treatment that is really tailored to the individual tumor of each patient in the aggressiveness, but also in the targeted approach. And I hope at some point we will be there. It will take a couple of years, but I think everybody is on the way. And I thank you for your attention.
Thank you, Dr. Eggert. Does anyone have questions? Okay, go ahead.
Hi. If a patient has a very small relapse that's in the bone, do you recommend, like in the femur, would you recommend biopsying that? We're at a smaller hospital and they recommended it, but or they said they could, but it would come with a lot of risks, like potentially breaking the bone and being in a cast and things like that.
It depends on the technology of the biopsy, how it is taken, but usually I've never seen that a bone is broken by taking a biopsy of a bone lesion. I would, because it can give you information on targets that you might want to have in hand.
Okay. Also, do you have an example of getting a biopsy where it changed treatment? It wasn't ALK, but there was a targeted treatment and you saw it make a real difference in the patient's outcome?
Well, our treatment, of course, is always a combination, and we combine molecular targeted treatment with a backbone of chemotherapy. So you will afterwards never be able to say it was the only part of this molecular targeted treatment, but yes, also for other targets we have seen quite impressive responses, but as these targets are quite rare, we do not have the proof of concept in clinical trials yet because it's not enough patients. And in the future, I really think we have to find individual ways for each tumor profile to treat them with a combination of targeted treatment, but also we have even this morning heard great talks about immunotherapy. It will be a combination of immunotherapy and targeted therapy, and also the new upcoming immunotherapies are targeted. So they are targeting different surface antigens, proteins on the tumor cells, and the more we know about the molecular makeup, the better we can choose the appropriate therapy.
That makes sense. I have one more question.
Sure.
If that's okay.
Go ahead.
If there were multiple bony spots in a relapse, would you recommend biopsying each bony spot?
No.
Maybe just one?
No, I think one is sufficient to get an idea because they will have seeded based on the same clone initially. If it's a relapse now and the second relapse 2 years later, then I would go for another biopsy, but not at the same time.
Okay, thank you so much.
Anyone else have any questions? Okay, go ahead.
Correct me if I'm wrong, but I seen on one of your slides, like there was like cisplatin resistance, etoposide resistance. Is it something you guys are working on to see if certain gene mutations or amplifications are resistant to certain chemos, or is it like each patient's tumor biopsy, you're seeing if they're resistant to certain chemotherapies?
Well, what we see, an example maybe again from the ALK inhibitor world, we see that some of the patients after several months, after a very good initial response, do not respond anymore. And then if we analyze the tumor tissue again, we see that there are new mutations that have developed under this targeted treatment that are stopping the response to ALK inhibitors, but on the other hand are opening up new avenues for different targeted treatments. And so based on that, we could switch the treatment and get to a new response again. So it's very important to study exactly on the molecular level what's going on to have an idea how the tumor responds. A tumor is very smart, unfortunately, and finds new ways of wiring of signaling cascades. But then if you identify them, you can react, and of course we would all dream of in the future not reacting but predicting. And being proactive about that and not waiting until there is a resistance and a non-response, but predicting what will happen in the future and then being able to choose the right combinations to prevent that. But that's our dream for the future.
Yeah. Okay. Thank you.
Anyone else have any questions? Okay. Thank you, Dr. Eggert. Appreciate it.
Thank you very much.